Thank you very much for that kind introduction, Stacy. Let's get started. So, hello, everybody. My name is Alex Masono. I'm an interventional radiologist. I practice in Orange County, California. It's a great pleasure to have all of you here today and my esteemed faculty as well. And I also want to welcome you to our webinar. It is entitled Biopsies, the Time for Change is Now. This webinar is brought to you by Single Pass in collaboration with the Society of Interventional Radiology. In this inaugural Industry Insights webinar, we'd like to share novel technology designed to change the way that you perform percutaneous biopsies. The single pass device is the first of its kind, a one-of-a-kind device designed to close percutaneous biopsy tracts, thereby reducing the risk of bleeding, saving resources, and improving patient care. You will hear much more about this device shortly. This is a brief agenda for the webinar. Our chat box will be open for questions that we'll answer. And we also are planning to have a few quick polls, so have your phones and mice handy for those questions. So you already know me now, but I'm also joined today by Dr. Francis King, Chief of IR at Robert Wood Johnson University Hospital, New Brunswick, and Clinical Assistant Professor of Interventional Radiology at Rutgers, as well as Dr. Nami Azar, Professor of Radiology at Case Western Reserve University and University Hospital of Cleveland. So thank you again to my faculty for joining us today. They will be up shortly. But before we move on, I would like to do polling question number 1. We'll have that pop up here in a moment. The question is this: so if you perform biopsies regularly, have you or your partners experienced a significant bleeding complication within the past year? And the choices are yes, no, or maybe you have, but maybe it wasn't within the last year. We'll give a couple seconds for you all to answer that question. I'm definitely looking forward to seeing what the results are. All right, so let's take a look. So it looks like actually quite a few of you have in fact experienced a significant bleeding complication within the past year. Only a minority of you have said, basically just said no. So I think we're all pretty much in the same camp. If we do enough biopsies at some point, we will have a complication. So with this, I would like to have Dr. Kang take over. He is going to actually introduce the single pass device to all of you and share some of his extensive experience with percutaneous biopsies using single pass for biopsy tract closure. Dr. King?
All right, hi, my name is Francis King. I'll be discussing the single pass Chronos electrocautery device. In this presentation, we'll discuss the following topics: technology overview, best practices, case selection, then we'll go over some cases. Potential complications from any biopsy include bleeding, infection, injury to regional structures, and tumor seeding. We currently use manual compression, autologous clot, gel foam, EmboCube, BioSentry, and other embolics for biopsy tract closure. However, we need more effective and efficient device specifically indicated for biopsy tract closure. Single-pass Chronos electrocautery is classified as the first disposable battery-powered electrocautery device utilized to control bleeding post-biopsy procedure of solid organs. This innovative approach ensures that the hemostatic technology directly seals the biopsy tract as the device is withdrawn. By utilizing controlled thermal energy to actively cauterize the tissue, the physician gains an exceptional level of immediate control, significantly reducing the likelihood of bleeding upon final needle withdrawal. A key advantage is its seamless integration into the existing coaxial workflow. It functions reliably within the same coaxial introducer needle used for the biopsy, meaning no additional punctures or excess manipulations are required. It has the FDA 510(k) clearance. It is considered a Class 2 electrosurgical device. The FDA's explicit indications for use validate the device's capability to achieve hemostasis through coagulation in liver, kidney, and lung. It is powered by 2 AA batteries. It is a stainless steel distal probe with a rounded heated tip that is connected to the handle to cauterize targeted areas of tissue. The tip is heated 75 to 85 degrees via electrical current through a coiled wire. The temperature of the distal tip is controlled with a thermistor, while the temperature of the tip is distributed with a thermal conductive epoxy. It is a 0.040 inch outer diameter, which is compatible with 17 gauge guide needle. It is available in two models, K10 and K15. K10 model has a 17 centimeter working length and is compatible with 10 centimeter guide needle, whereas K15 has a 22 centimeter working length and is compatible with 15 centimeter guide needle. The ergonomic handle includes an on-off switch and a push button to activate the heated tip. So how do we use this device? I will demonstrate how the device is used at the time of biopsy. Before single pass device is used, we need to prep the device prior to starting the biopsy. First, remove the sharp stylet from the guide needle. Place a single pass probe into the guide needle, then connect the guide needle hub to the depth gauge hub. Slide the depth gauge and guide needle until the tip of the single pass probe is exposed at the same length as the biopsy gun sample length setting. Twist the depth gauge to secure it in place at the adjusted position. Make sure it's very tight. Take the single pass probe out from the guide needle, and now it is ready to be used after the biopsy. Proceed with the biopsy under image guidance. After the biopsy is done, remove the biopsy needle from the guide needle, then grab the single pass device and turn the switch on. Insert the single pass probe through the guide needle and twist the lure to securely connect the single pass to the guide needle. Press the button and hold it for at least 10 seconds to achieve the maximum temperature. It is very important to keep the device in place without moving it while pressing the button for at least 10 seconds to ensure the optimal rise in temperature to achieve the maximum temperature. The technique may vary from operator to operator, where some may hold for longer than 10 seconds. I personally hold it for 20 seconds or even longer if I'm particularly concerned about bleeding, including patients with underlying coagulopathy or in hypervascular tumors or patients with lupus nephritis. And slowly withdraw the whole system, including the single pass probe locked in on the guide needle until you are just outside the capsule of the visceral organ. It is very important to withdraw slowly to ensure optimal cauterization. When withdrawing slowly, the technique may vary from operator to operator, where some may withdraw more slowly. I personally withdraw 1 centimeter every 3 to 5 seconds, and it may take longer when I'm particularly concerned about bleeding and hold it in a bit longer at the capsule. Sometimes tissue charring can occur, and the tip will adhere to the surrounding tissue as you withdraw it. If that happens, then you can twist the whole system to make it free of the surrounding tissue. You could continue to slowly pull it, but it can jump with the tension as it becomes free. Other option is let go of the ultrasound probe and use the other hand to assist in pulling the guide needle from the skin. Obviously, you can always do that for CT cases. The patient sometimes may feel pain when withdrawing at the capsule, but it can be mitigated by adequate local anesthesia and sedation. We'll now discuss about case selection. Our single institution experience included a wide range of anatomical targets, demonstrating the device's broad clinical utility. The chart details the composition of the 109 biopsies broken down by target organ and tissue type. It included 52 liver biopsies, with majority being liver mass biopsies, and 30 renal biopsies, with majority being parenchymal biopsies, and 27 biopsies from other categories, including biopsies of tumors of the lung and other locations outside of product indication. The majority of procedures were performed as an outpatient. Typically, the major bleeding rate for liver biopsies is about 0.5% to 2%, while for kidney biopsies, it's around 1.9%. From our single institutional experience, no major bleeding was seen from liver or renal biopsies. Only one major bleeding complication was observed out of 109 biopsies. It was from a biopsy of a retroperitoneal mass that resulted in left psoas intramuscular hematoma with CT showing a small pseudoaneurysm, which was subsequently embolized. Note that this biopsy target was outside of product indication. Also, the complication was not attributable to the single pass device. So now we'll go over some cases. This was a 73-year-old female with instantly found right hepatic mass. The ultrasound images demonstrate single pass being withdrawn from the liver with successful biopsy tract closure. The biopsy came back as cholangiocarcinoma. And you can see the echogenic linear line of the tract closure, and then post biopsy showing no bleeding. The second case is a 35-year-old male with proteinuria. The ultrasound image demonstrate a single pass being withdrawn from the kidney with successful biopsy tract closure. And with the post biopsy image demonstrating no bleeding. And this is the last case. This was a 54-year-old male with a metastatic colorectal cancer, so that's post multiple resections with recurrent liver mass located centrally. The CT demonstrates biopsy being performed in post biopsy images after the biopsy tract closure with single pass device. And that's it. Thank you. And any questions?
Dr. Kang, thank you for sharing your experiences. You've done a lot of cases. You and your partners have done a lot of cases. It's incredible. One of the questions that I personally wanted to hear from you was the learning curve. So, what is the learning curve like? What has it been for you? Maybe also your staff. So like your nurses and techs who may be assisting you with these cases and their feelings on the device. And of course, I understand you have trainees. So. What is it like for them as they learn to use the device, incorporate it into their workflow? Can you share a little bit?
Yeah, I think the learning curve is pretty short. I think it was pretty self-explanatory when we first learned how to use this device. I think it took about 1 to 2 cases to be comfortable with the device for me and our faculty and our residents. Um, as we used more, the prep time got shorter and shorter, and now it takes less than a minute to prep the single pass device prior to using it.
Do you have a sense for how many cases one might expect before they feel fully comfortable with it? Is it just, I mean, a couple cases or lots of cases or?
I think we most of us got comfortable after about 3 to 5 cases.
Yeah. And do you feel like your techniques evolved at all? I mean, you shared a very kind of regimented, organized approach, which I really appreciate. How has the technique changed for you since you started? You started out when when you first did the first case, probably nobody done one before in humanity, right? So now you've had a chance to do lots of cases. How have you changed the way you think about the procedure and the tract closure?
Yeah, I think because we have the real-time ultrasound image guidance, especially when you're looking at in real time, I think it helps understand where, how you're cauterizing the track and actually close the track. So I think by about 10 cases, I think we were able to kind of figure out how maybe we need to keep the device in a little longer to get more adequate track closure, things like that. I think obviously it came with a little bit of experience, but I think by about 10 cases, I think we were very comfortable when we're able to kind of manipulate how we actually close the track.
Yeah. Thank you for that. So it sounds like not a lot of, we're all pretty good at what we do. We can go up that learning curve rapidly and get comfort. And of course, some of the innovation around technique you've already done for us and kind of trained us on. I do have one last question, if I may. I'm curious how this compares in your mind to the other techniques you mentioned, right? So you listed a bunch of different ways you can perform biopsy tract closure. I presume many of those ways you used to do. How does this compare using single pass electrocautery? How does that compare to the previous techniques that you were used to?
I mean, we were using gel foam initially, and then we've tried some autologous blood as well, like a blood patch, and then we've kind of moved on to EmboCube as a group. And I think when we use the EmboCube, when we're using the liver or kidney in real-time ultrasound, you see that go somewhere, right? We see that initially we go, it can go into the portal veins or hepatic vein branches, or even in the kidney, you see that it kind of spreads into parenchyma, and we're kind of a little concerned all the time, and that's why some of our faculty never use them at all. And so I think once we saw this device and we use it in real time, showing that, it wasn't really damaging any other, it wasn't, shunting somewhere else, or it was actually infarcting the kidney, things like that. I think what it gave us the assurance when we were actually visualizing in real time without, with the EmboCube that causes shadowing, things like that. So obscures the view at the end. So I think this kind of helped us visualize what we were doing.
Thank you. Thank you for your answer. I think to summarize what you've said is how I view it too, is just control. I feel like you just have control the whole way through. and you can right, you can take care of the problem and watch it being taken care of. So I appreciate that very much. I am actually going to do another polling question here now, if you can have that pulled up. This will be another fun question, of course, right? So there's always a patient behind the story, right? So how concerned are your patients about bleeding after biopsy, right? Patients go on the internet these days. They're reading about the risks and benefits of their procedures. How do you think they perceive percutaneous biopsy? So I'll give it another second or two, and then let's see how it shakes out. All right, let's check it out. Let's see how you all voted here. So again, a third of you said your patients are very concerned about bleeding after biopsy. Half of you said patients are concerned, and the remaining 18% of you said the patients are not concerned. That's a pretty interesting breakdown. The majority, the vast majority of us find that our patients are concerned, and I certainly feel that that's the case in my practice as well. So I'd like to take a little bit of time here and talk about, we're going to title my section Past, Present, and Future. And really what I want to do is talk a bit about data, share some of our own data as well, just like Dr. Kang, and then show more cases, because that's where we learn from each other the best. We are image-based specialists. That's what we want to see. So biopsies, right? It's one of the most common things that we do, but they carry risks. Historically, hemorrhage has been that single largest risk we know and we fear, and yet we had no way to predict who was to bleed. And maybe this would be another good polling question, but I think the ones you expect to bleed the most never bleed, and the ones you never gave a second thought, those are the patients who seem to bleed, right? And so this kind of weird thing, this frustration and this fear uh, really took a lot of our mind share, and yet no device ever existed. In the literature, frankly, the clinical experience shows that these rates are pretty significant. In my opinion, the literature underreports bleeds. Uh, I think most of us would say, let's take kidney, for example, here, major bleeding rate of 1.6% and an embo rate of only 0.3% for a medical renal biopsy is amazing. This is what's in some of the literature. I think most of us are living with rates higher than that. We should not be embarrassed to admit. And we haven't even discussed the role of blood thinners and the increased risk associated with either stopping blood thinners for intervention for a long time in some cases, or patients are on blood thinners perhaps that we don't know about. So data-wise, that single pass device has achieved FDA clearance. This is a commercial device that you can use today. It achieved approval based on data from 2 centers, predominantly liver and kidney, but also lung, and there was a 100% procedural technical success rate. And at Hoag, we've done actually not, this is dated now. I made these slides just a couple weeks ago. We're probably nearing 200 cases since inception. And we started off trying to decrease bleeding in the highest stakes biopsies. So what do I mean by that? I mean, these are patients that are otherwise healthy. So maybe it's your 46-year-old with fatty liver that needs a liver biopsy. The 35-year-old with lupus who needs a renal biopsy. A severe complication can literally upend these patients' lives. So a great place to use this device. But as we've used it more, we've realized, well, this is also a way for us to obtain better tissue samples more efficiently for a variety of important conditions such as liver mass, renal mass, transplant biopsy. Because I'll tell you what, I didn't always use 17 gauge biopsies for those, or 17, 18 systems for those biopsies, and now I do with significant comfort. Forewarning, there's a pun coming, and a pun is very much intended, but our core business is safer and more efficient and more effective. So we took a sneak peek or this is a sneak peek of the data we have in our center. I looked at the first 6 months or so of adoption, and in this sample size, we have about 120 patients across organ systems, predominantly liver and kidney, and a mix of ultrasound and CT guidance. And about 20% of patients were on some form of blood thinning medication prior to intervention. And this is pretty would say, preliminary, but in our 120 patients, procedures were quick. Patients went home quickly. Uh, there were no overnight stays of any kind, including all renal biopsies. So this is an average of all those. 3 hours on average, patients were gone. In a 30-day follow-up period after intervention and tract closure, we found 0 transfusions, 0 readmits, 0 IR angiogram, and 0 mortality events. So that's pretty great. And in this, I think this is the largest case series to date. We're happy to report the tract closure with single pass is really cementing its role in everyday biopsy for us. And we're pretty optimistic about where this is going to go. So let's look at a couple cases, and then I'll let you go here and have Dr. Azar talk to you. But here's a liver biopsy closure at work. And so you've got the single pass bubble cloud, and then you've actually got portal venous gas, which is kind of cool, showing the device is working. And here is a video of that. So you see this cautery cloud and this adjacent gas as the device works. And then as Dr. Kang showed you too, you really can see the device super, super clearly under sonographic guidance if you desire, such that you have full, clear cautery visualization. And this is not like a gel foam slurry, which always to me looks like a bomb went off in there. I'm in full view, in full control every single time. So generally, I don't, by the way. I mean, that's a nice video for showing you. I don't perform these with imaging guidance. I do it purely by touch. So, if you need a friend to help you screw the thing on, no problem. I cauterize for a full 30 seconds every single time, sometimes longer. And then I pull very, very, very slow, particularly for the first cm or two. And then I pull essentially as slowly as possible, as humanly possible, all the way out. If the device, let's say, feels like it's stuck a little bit, that's actually good. It's charring. Just rotate the device, and I don't try to time anything. My finger's on the trigger the entire time. So that's kind of how I think about it. My 2 cents. If you do your medical renals with ultrasound, you can see here another case. Arrows are pointing out that nice white cautery cloud. Here's a case of a different medical renal biopsy where I got a perinephric hematoma during my access. And I've marked that for you in that white circle. I put in a single pass device and the bleeding stopped, and I sent that patient home 4 hours later. Here's another one where I did a single pass and you can't even tell I did it. A lot of the time you can't even see, there's no evidence I was even there. Here's another case, Carter again, that you can't even see it, clearly effective, but it just is like I was never even in the organ to begin with, time and time again. So pretty neat. And then, sometimes they'll throw a difficult liver lesion at me and look at this thing. This is like a centimeter mass. I want to place the biggest possible biopsy needle I can to get tissue, maximize my chances of getting tissue, and then cauterize my way out of there to be safe. And that is indeed what I did here. You see my needle placement. This was diagnostic. Or maybe it's a lung biopsy, difficult lesion. Generally, I've been a 19-20 gauge biopsy person, but I have found that a 17 gauge gives me a lot more control and increases my chance of getting diagnostic tissue. Closing with single pass has allowed me actually to also avoid pneumothorax in all the cases that I've used it for. So in conclusion, and this brings me to the end of my section, but we no longer live in the dark ages of biopsy. Single pass has changed the way Dr. Kang, Dr. Azar, and I are doing our biopsies, how we are accepting the cases, how we perform the cases, and when we discharge our patients. So the future is bright, and it is indeed heating up. So thank you very much. And before I turn it over, I did have a question that popped up while we were discussing related to this actually from the audience, and it was about consent and consenting for cases. I would say that my risk profile for my biopsies, including high-risk biopsies, has changed dramatically since this device became available. So I guess I don't have to scare my patients. I'm trying not to anyway, but I don't have to scare them because I can tell them, hey, there is a bleeding risk you're going to read about. if you Google this or ChatGPT this question. But unlike the vast majority of centers, we're an early adopter of this technology, and I'm going to cauterize that biopsy tract afterwards. So it makes the consent process much more pleasant, and the patients are really thankful that they're in a center that is able to offer such a technology. So at this time, we have, I believe, one more polling question that I'm excited about. Let's see if we can get that up. The question here is, how disruptive is a significant post-biopsy bleeding complication to your practice workflows? I am not going to lead you on this question, but for me, if I did a renal biopsy and suddenly there's a renal angiogram with embolization that needs to be done, that is incredibly disruptive for my practice in just the workflows. But I'd like to see what you all think. And then shortly, Dr. Azar, you are on deck, so we'll call you up next. So let's see what folks say. Looks like you all agree with me. So let me do the math here. 96% of people think that it is either disruptive or very disruptive to have a significant bleeding complication disrupting your daily workflows. So I think that is in line with my expectations, but it is remarkable to see. So now I'd like to turn it over to Dr. Azar. Take it away. We're going to hear about clinical practice and actually some of the business case.
Thank you, Dr. Misono. So I will share my slide deck here. So as you know, my colleague mentioned before, really single pass changed the way we practice and changed the risk profile. For myself, what I do, I'm going to play this video for you. This is a renal biopsy. And what I do in those cases, I always put color when I'm pulling the single pass. And you see the generation of heat when you are cauterizing the track, generate twinkle artifact, which from my point of view, always very helpful. I'm a visual guy, so I like to make sure that my single pass is really working well before I go ahead and retrieve my needle all the way outside. So I'm a big fan of ultrasound. I'm a big fan of the twinkle artifact we see every day. And I use it every time I use single pass, when I can see it, of course, with ultrasound. So I'm going to talk a little bit business, and forgive me, this is kind of annoying part a little bit, but still is very important for our practice. So when we talk about recovery, and all my colleagues talk about recovery before, recovery billing is not really standardized. It is part of the patient care and depends about the institution. It's very variable, but there's no standard billing code for recovery. So some procedure, let's say, if we talk about, for example, lumbar shunt includes overnight stay for the patient, but some procedure does not have a standardized billing code after the procedure. So I'm just going to give an example, my institution. So for all our IR services in our institution, we use a base charge of $200, and that's followed by $23 a minute. That means every minute really for the patient stay extra in our recovery area is going to cost $23. Now, when we talk about complication, now billing for complication is completely different. So basically, I like to add some CPT code. So the first CPT code is 99291. This is include for acute care provider. This is the first 30 to 74 minutes they use that. And the hospital average charge is around $3,800. They get paid around $1,800. So this is very expensive, and that includes the ICU plus the acute care provider time. After that, we're talking about 99292, which is a different CPT code, and this is a 30 minutes block, which is increased every time the patient spends extra 30 minutes in the ICU. And the billing on it is around $1,400. The average pay around $567. So let's say just for the compensation here, and to make it easy, let's say $500, the average cost per 30 minutes for the patient stay. Now, as Dr. Misono mentioned before, rarely, sometimes we need to use embolization, and the CPT code for this will be 37241 and 37244. The average cost for the institution for those codes around between $8,000 to $15,000. This is just cost before the insurance. Of course, if you're going to add the cost for transfusion, ICU stay, admission, is going to make the numbers extremely high. And this might reach approximately $30,000 total for average bleed with 2 days stay in the hospital and 1 day of ICU. So now this is our experience with kidney biopsy, which I'd like to share with you. So when we talk about kidney biopsy, and my colleagues mentioned that before, the average stay for those patients is very variable, but approximately range between 4 hours to 24 hours. So some institution, they admit their patient overnight to watch for bleeding. Overall, the longer the recovery is associated with increased spending for the institution, and also limits, as Dr. Misano mentioned before, if you have a bleeding or anything interrupt your workflow, that's going to really shut down your turnaround time of the room, which is also very expensive. Overall, early discharge and decreased incidence of major complication is very effective cost-saving method. So as my colleague mentioned, of course, our numbers are a little bit different, but those are the average number. When we talk about complication from renal biopsy, it's around 2%. Complication required transfusion depends where you read it, around 2%. Embolization risk around 0.5%. And this is why we got this question. We try to ask ourselves, does cautery-assisted renal biopsy lower complication profile and has a cost saving for the institution and for our patients? So this is a work done by myself and my great resident, Dr. Stevens. So percutaneous native biopsy, we know is a very commonly performed procedure. And nowadays, because there's a more demand for a specific diagnosis, we're going to do more and more kidney biopsies. Long observation, of course, is going to strain the department and is going to increase the cost, as I mentioned before. So we look into comparing those numbers, and we look, does cautery assisted, like the single pass hemostasis, affect the cost of the hospital? Our major impact was, of course, procedure recovery time. And the other thing we look for is the risk of complications. So we just have 22 patients, a very small sample. But among the 22 patients, we look into those patients, no major complications were reported. We look on all these patients, we had a follow-up on them. We have only 2 patients, they have a trace perinephric fluid. Now we can argue this is small hematomas, we can argue it's lidocaine injection, etc. But none of those patients require extra stay. None of those patients need to be in the ICU setting. All those patients went home 2 hours approximately after native kidney biopsy, which cut our admission time from 4 to 2 hours. Now, this is our numbers here. So basically, we look an average cost for a standard biopsy, our recovery time around 4 hours, sometimes a little bit longer. So it was average 300 minutes. With a single pass biopsy, our average recovery was 141 minutes. So if you add those numbers I mentioned before, of course, here I subtracted from you the $400 cost of the single pass. So our cost for a standard renal biopsy was $6,900. Our cost we're using the single pass around $3,257. That's including the value or the price of the product. Of course, here we are not discussing the added value, which we are not really calculating, is your increased turnaround time in the room, all this patients, and also patient satisfaction. Because anytime you have a patient with bleeding, etc., that's going to really drop your satisfaction rate, and it's going to reflect indirectly on your compensation. Of course, we need a large sample to validate the cost saving we're talking about, but this is our initial observation. Now, as my colleague showed, I will show you a few cases here. So this is, we're using infusion technique here. We're just biopsying MS lesion in the liver. And as you notice, there's a little bit trace perinephric fluid. And as you know, this will increase this risk of seeding in those cases. So went ahead and we used single pass. And again, I'm a big fan of color. So here you can see the twinkle artifact while we're retrieving the product. And this way, you know that your device is heating up and you are in a good shape. Now, this is a CT-guided biopsy. So I was biopsying an internal iliac, lymph node. And as you notice, I start developing hematoma here. I've never used single pass with CT, but I used the device. I went ahead and I inserted through the coaxial system and I cauterized the track. Of course, I knew it was not the internal iliac. I knew it was not the external iliac. However, one of those small vessels was bleeding. And this is the follow-up was performed just after we completed the case. And you see here the small perinephric hematomas. There's a little bit air from our cautery device, but actually the patient went home 2 hours later and he did very, very well. So in my conclusion, I think single pass can shorten recovery time with positive impact on the institution and patient. If we have decreased the incidence of complication, bleeding, tumor seeding, etc., that will have a great significant impact on the institution. As my colleague mentioned, it will help the operator to perform solid organ biopsies when coagulation parameters are not ideal. And now for IR, we have a big demand to do more and more with less perfect coagulation factors. Color Doppler, it's my baby. I love it. I love the twinkle artifact. I use it all the time. It's very easy to use and it's extremely helpful. You don't have to count seconds like my colleague do. Just look for the color and follow it. Thank you all.
Thank you, sir. That's a really eye-opening and thought-provoking presentation. I loved your biopsy of the iliac artery case. That was entertaining to watch. And actually, but jokes aside, I really love your ultrasound mastery and kind of color twinkle artifact visualization of the device. That's really, really clever. I wish I had thought of that, but I will start to do that. Related to that, I do actually have a question. You have great images of visualization. Do you think that's needed? How do you operationalize it in your practice? You did a CT case where clearly you did the whole case without, quote, watching, for that ultrasound image. How do you think about that in your practice?
I mean, for sure, the device comes really handy when you see you're really into a problem and you need to have a quick solution, as you saw on the CT case. Overall, I really like to use color. And the reason for that, whenever you see enough twinkle artifact, you can now safely remove your needle. And as you guys do, I do pull it slowly. And that's really helped me to make sure that I get a nice cauterization of my track.
Thank you. I was really fascinated by the way that you're improving, sounds like improving throughput and time really for your renal biopsies. So we are doing at my institution 4-hour discharges. I'm curious kind of where you are now, and where do you think maybe a year from now, 2 years from now, do you think you're going to get even more efficient at getting your patients through the hospital because you have cautery at your disposal?
So, we work like a machines actually. So we do average between 12 to 16 cases a day, just personally.
Wow.
And the recovery from renal biopsy went down. We have 12 beds for outpatient recovery in our institution. So having those quick turnaround and sending those patients after 2 hours was extremely helpful and increased the output of our department. I can tell you the administration is very supportive of the products because they saw that down improve output of the section, and they really not really complaining at all about the price of the product at all. As you know, for IR we use very expensive stuff. Everything we use is very expensive. So in the big scheme of things, this is really not an expensive product.
Thank you. So if I may, actually going to have, I have a question or two for both of you, and maybe I'll ask the first question of Dr. Kang. I think that the human element of the biopsy business really cannot be overstated. And one of the poll questions got to that. Right? Patients are kind of scared of this. The question for me about consent got to this as well. But there is really something very human about undergoing a procedure that's scary in a bleeding complication that cannot be predicted. Dr. King, has this changed the way you do biopsy, the single pass device? And in what way has it changed the way you view percutaneous biopsy?
I mean, obviously, we all deal with complications post biopsies, and especially when we have that major bleeding kind of cases, it kind of scares you, right? So we had a very young patient in there, who was 12-year-old with a lupus nephritis. We did a biopsy, and patient subsequently, had bleeding and then had page kidney, and actually required nephrectomy. And we discussed at the multidisciplinary team involving urology, ACS team, and the medicine team and nephrology team as well. And it was pretty hard because, like, nephrology always thought that the bleeding rates from kidney biopsies was pretty low, especially the major bleeding rates. And then when we discussed that one case, and it just kind of like for that patient and the family, it's just a big thing. So when we encountered this new device, we were like, huh, I mean, this could change the whole biopsy, the field. And so it kind of gave us more reassurance. And as we used more, I think we had patients recover less in the holding post biopsy, confirming with the frequent ultrasounds to making sure that there was no hematoma forming, things like that. And after multiple times, and then with that reassurance, it was really helpful. And that safety and direct observation of that effectiveness was really helpful. And also the patients are now able to go home early, things like that. And more patients are happy. And so yeah.
Thank you for sharing that. Dr. Azar, do you have any thoughts related to, I guess, the human element of this business?
Of course, I mean, we are humans, we're dealing with the humans, and I've been doing it for 22 years. But when complication happens, I do not sleep for a week or so. So that's even not just on the patient. We're not even talking about the patient side effects. Those patients, they're suffering even way more. But even for us as a human, it's a big, big tragedy, even regardless how many thousand kidney biopsies you do. And I think this has really changed the dynamic completely for us. And the only things I want to let everybody know is the only things I pay attention to it when I use any cautery device or any ablation device, when there's a bowel in the neighborhood, when I'm saying the bowel are close, with, let's say within half a cm. Just pay attention to this. Otherwise, the device will make a huge impact on your practice.
Well, thank you for all of the tips and the perspectives. I think that brings us to the end of this session. There are additional questions that are quite insightful in the chat. We will promise to follow up with you about those questions. We couldn't get every single one answered here, but thank you very much, everybody, for your time and attention. We discussed today the ever-present bleeding complications that can be associated with percutaneous biopsy, part of, again, the human nature of what we do. But we did discuss that there is a solution for that now with the single pass device stopping bleeding in the biopsy tract. And we certainly look forward to further conversation. And all my faculty here tonight look forward to staying in touch with you all. So please do reach out. Additionally, there is the email address for further questions, as well as our QR code that links to the website for single pass. So thank you very much again, and thank you to the Society of Interventional Radiology for hosting this inaugural webinar. Thank you, Dr. Zar, Dr. Kang, and have a great evening.
Thank you, Dr. Masona. Thank you, everyone.
Thank you.